இப்பதான் 53 பேரு. வாய்ப்பே இல்ல நல்லா கவனிக்கிறது. ஒண்ணுமே
பத்து மணிக்கு தான் செஷனே ஆரம்பிக்குது.
Am I audible, sir? You can proceed.
With innovation and with immense pleasure, I thereby extend a warm wishes from Vivekananda Dental College for Women for holding up the Physiology lecture series on the subject Cardiovascular System and the Physiological Aspect, conducted by Vivekananda Dental College. We are very much anticipated with the upcoming CDE program and feel much pleasure considering that we are going to be enlightened by the knowledge of our superior faculties who never fail to give a spark in young people's mind. Hospitality, in general, is a communion that blooms of connections within and is improved by sharing. To such a great communion, I welcome Dr. Purushottam to share with gratitude his words of welcome.
Good morning to all. I welcome you all for the Physiology lecture series on cardiovascular system. On behalf of Vivekananda Dental College for Women, I welcome all our guest speakers and the students of Vivekananda and other college students. I welcome you again for this lecture series. Thank you. Welcome our guest speaker, Dr. Mukhilan sir, to present the topic. Before to present the topic, I would like to invite our guest speaker with a small introduction.
Now, I held forth the gratitude within in welcoming Dr. M. Mukhilan, BDS, MSc, PhD, who completed his undergraduate degree in dentistry from Rajamuttaya Dental College, Annamalai University, did his post-graduation in medical physiology from Savitha Medical College, Chennai, completed his PhD in medical physiology from Vinayaka Mission University. He has 12 years of working experience in teaching physiology for BDS and MDS students. Presently, he is working as Associate Professor and Head in the Department of Physiology at KSRU Institute of Dental Science and Research, Junction. Now we call upon Dr. M. Mukhilan to insight us about cardiac cycle. Welcome, sir.
So now you can share your presentation, sir.
So can you able to see the slides?
Yes, sir. It's visible, sir.
Yeah, thank you, sir. So first of all, I would like to thank the organizer, Dr. Purushottam, Reader, Department of Physiology, Vivekananda Dental College, for organizing such an event for the beneficial of the students, especially for the first years of dental and allied health sciences. So this will be very much useful for the students to get an overall idea about the cardiovascular system. So let us move on with the topic. I'm going to cover the introduction to cardiovascular system and cardiac cycle. So to say about heart, it is the organ which is formed in intrauterine life, which starts to function from the intrauterine life until the death of an individual. So the heart plays a vital role for every human being. So when we say about heart, it has different properties: excitability, conductivity, contractility, auto-rhythmicity. So when we say about excitability, any tissue, when a subthreshold stimulus is given, it can able to excite. The excitability, it is not only for cardiac muscle, it is for all other muscles like the smooth muscle, the skeletal muscle, and also for the nerve. These tissues can able to excite when the minimal stimulus is given to the tissue. So they'll generate action potential, and the action potential is conducted from one part of the tissue to the one part of the cell to the another part of the cell. The next property is contractility. So apart from the nerve tissue, the muscle tissue has a property of contractility. The muscle tissue, when a threshold stimulus is given, the action potential travels along the cell membrane of the tissue, and it can able to contract. Shortening of the muscle takes place. The next property is autorhythmicity. The autorhythmicity, it is a unique property of the cardiac muscle. Not only for the cardiac muscle, it is also applicable for the smooth muscles. The smooth muscle, they too have the autorhythmic property. The autorhythmicity is nothing but it is a specialized type of contractile, not actually a contractile element. It is different from the contractile element. To say about the autorhythmicity of the heart has the SA node. The SA node, it is a specialized cardiac muscle fiber. It lacks the striated fibers, like the actin and myosin. It lacks of actin and myosin, but it can able to excite impulse on its own. So that is called as autorhythmic impulse. So the SA node, not only the SA node, the AV node and the Purkinje fibers, right and left bundle, all these fibers can able to initiate its impulse on its own. So I'm going to show you a slide, and this is the pacemaker cell of intestine. And can you post the answer in the chat box? What type of cells which is present in the intestine, which give rise to autorhythmic impulse in the stomach and intestine? What type of cells it is? So like SA node, the intestine also have the cells like intestinal cells of Kajal. They will generate impulse, and impulse is sent to the smooth muscles of the intestine. So not only the cardiac muscle like SA node will have the autorhythmic activity, the smooth muscles of the intestine, gastrointestinal tract will also have the autorhythmic activity. Okay. So when the impulse are generated, the generated impulse has to be transmitted from one part of the cells to the another part of the cell. So this property can be said as conductivity. The impulse has to be sent from one part of the cell to the another part of the cell. So when we say about the cardiac muscle, it is striated like skeletal muscle and involuntary like the smooth muscle. So the cardiac muscle, they are branched and they are held together by the desmosomes. You can able to see the desmosomes here in the slide. The desmosomes, the cardiac muscle fibers are held together by the desmosomes. We call it as the junction between the two cells are called as the intercalated disc. So this forms a junction of two cardiac muscle fibers. And how could the impulse from one cardiac muscle fiber will be transmitted to the another cardiac muscle fiber? It is through a type of junction called as gap junction. The gap junction forms connection between the cytoplasm of one cardiac muscle fiber to the cytoplasm of the another cardiac muscle fiber. This facilitates, the gap junction facilitates the movement of impulse, the transmission of impulse from the one muscle fiber, cardiac muscle fiber to the another cardiac muscle fiber. So with this presence of the gap junction, the atrium acts as a single unit. The ventricle acts as a single unit. We generally call it as the atrial syncytium and ventricular syncytium. The atrium acting as a single unit is called as the atrial syncytium, and the ventricular acting as a single unit is called as ventricular syncytium. Syncytium is nothing but acting as a single unit. This action of single unit is contributed by the all atrial cardiac muscle fibers are held together or connected together with the help of the gap junctions. This gap junction helps in transmission of action potential from one muscle to the another muscle fiber. Okay. Not only the SA node, the other nodes can also able to generate impulse. The SA node, the AV node, bundle of His, right and left bundle branch, and the Purkinje fibers. These fibers can able to generate impulse. We can otherwise say these fibers can otherwise can able to uh, generate impulse on its own, called as pacemaker. The pacemaker rate of the SA node, it ranges from 60 to 100, and my atrial myocardium, it cannot able to generate its impulse. The AV node can generate impulse at a rate of 40 to 55. Bundle of His, bundle branch, Purkinje network, these fibers will generate at a rate of 20 to 40 rates per minute. So when SA node is failure, the AV node can act as a pacemaker and can able to generate impulse. It can regulate the heart rate, but the heart rate regulated by the AV node will not be proper. There won't be even contraction and relaxation of the heart. It will be improper contraction and relaxation of the heart. So when we say about the conduction rate, the conduction velocity of the cardiac muscle, the bundle branches and Purkinje fibers, it has a high conduction rate. The bundle branch, the conduction rate ranges from 2 to 4, and also for the Purkinje fibers. So conduction system of heart, it has different fibers as we already discussed: SA node, AV node, right and left bundle branch, and Purkinje fibers. There are two type of fibers that conduct the impulse from in the atrium. One is the internodal fibers and interatrial fibers. Interatrial fiber, it is a fiber which sends the impulse from the right atrium to the left atrium. That is called as interatrial fibers. That fiber is called as Bachmann's bundle. And another fibers are called as internodal fibers. There are three internodal fibers you can see in the slide: anterior internodal fibers, middle internodal fibers, and posterior internodal fibers. So these fibers are respectively named as Bachmann's, Wenckebach, and Thorel fibers. The internodal fibers, anterior, middle, and posterior, are called as Bachmann's, Wenckebach, and Thorel fibers. Next, the impulse from the SA node will reach the AV node. The AV node, it is present at the lower part of the atrium at the atrioventricular right atrium at the atrioventricular junction. And the AV node will send the impulse to the bundle branches. It transmits the impulse to the right and left bundle branch, and it is transmitted to the Purkinje fibers. So this is the way the conduction system works: internodal fibers and also to the bundle branch and through the Purkinje fibers. So the innervation of the heart. The heart is innervated by both by the parasympathetic and also the sympathetic fibers. We all very well know the heart rate, the normal heart rate, it ranges from 70 to 80 beats per minute. So how does the heart rate is maintained at the rate of 70 to 80 beats per minute? The sympathetic fibers, those fibers are called as cardio-acceleratory fibers. And parasympathetic fibers, those fibers are called as cardio-depressor fibers. When the parasympathetic stimulation increases, it leads to decrease in heart rate. When the sympathetic stimulation increases, it leads to increase in heart rate. To say about the sympathetic stimulation usually increases during exercise, anxiety, depression. These conditions may increases the sympathetic stimulation. So this increases the heart rate. So in order to keep our heart rate at a normal range, both sympathetic and parasympathetic interacts and helps in maintaining the heart rate. The parasympathetic nerve is called as vagus nerve. So the vagus nerve plays a major role in reducing the heart rate. If there is no parasympathetic stimulation on the heart rate will increase more than 120 beats per minute. So the parasympathetic fibers plays a vital role in regulating the heart rate through vagus nerve. So this can be said as the vagal tone on SA node. The vagus nerve regulate the heart rate in maintaining the heart rate at a rate of 70 to 80 beats per minute. So it is called as vagal tone. Okay, let us move with the cardiac cycle. The cardiac cycle, it is a sequential event of contraction and relaxation of atrium and also the ventricle in order to pump the blood throughout the body. It is called as cardiac cycle. So when we say cardiac cycle, the cardiac cycle takes place both in the atria and also in the ventricles. The atrial event are called as atrial systole and atrial diastole. The ventricular events are called as ventricular systole and ventricular diastole. The duration of the cardiac cycle is 0.8 seconds. You all very well know about the duration. I am not nothing new to say about the duration of cardiac cycle, but I'll try to facilitate to understand the cardiac cycle easier. The cardiac cycle with the 0.8 seconds, the atrial event is also taking place. The ventricular event is also taking place simultaneously. So when we look at the picture, the graph, it is given in both the form and also in the circular form and also in the stretched form. The atria, it has atrial systole and diastole. The duration of atrial systole is 0.1 seconds and the duration of atrial diastole is 0.7 seconds. The ventricular systole, it starts after the atrial systole. The duration of the ventricular systole is 0.3 seconds and the ventricular diastole is 0.5 seconds. The last part of the ventricular diastole coincides with the atrial systole. The last part of ventricular diastole coincides with atrial systole. So the atrial diastole, it coincides with the ventricular systole and also the major part of ventricular diastole. We'll see about that, each event in detail. Okay, first, the atrial systole. The atrial systole is called as contraction of the atrium. When the atrium contracts, the blood is pushed from the atrium into the ventricle. You can see the arrows, red arrows. The blood flows from the atrium into the ventricle. As I said earlier, the atrial systole coincides with the atrial part, the ventricular diastole. That is the last part of ventricular diastole. Okay. Coming to the volume changes and the pressure changes in the atrium and also in the ventricle, you can see the graph. Two things are mentioned in the graph. One is the pressure graph and another graph is the volume graph. In the pressure graph, you can see two lines. One is the red line. Near to the red line, there is a dotted line. That is the pressure change in the atrium. And the red line, it shows the pressure change in the ventricle. First, we see about the pressure change in the atrium and the ventricle. So when the atrium contracts, you could be able to see there is a slight increase in the atrial pressure. That is the dotted line. There is a slight increase in the atrial pressure. And the blood is moving from the atrium to the ventricle. So the ventricular pressure also increases. The red line, there is an elevation in the red line. So it also increases. So this can be said as the red line, that can be said as last rapid filling phase or second rapid filling phase. The red line shows the second rapid filling phase. And coming to the volume change, you can able to see the blue line. The volume is mentioned as 50, 90, and 130. At the end of the ventricular systole, it can otherwise said as the last rapid filling phase of the ventricle, the last rapid filling phase, this last rapid filling phase, the ventricle, it has maximum amount of blood present in the ventricle. In the last rapid filling phase, there is the maximum amount of blood will be present. This blood, the volume of blood present in the ventricle will be around 130 ml. At the end of diastole, ventricular diastole, the amount of blood present in the ventricle is 130 ml. So this 130 ml, we can say the end diastolic volume. The 130 ml is end diastolic volume. So let us move on with the next cyclic event, ventricular systole. So why I am going to directly to the ventricular systole means the atrial diastole, it coincides with the ventricular systole and major part of the ventricular diastole. So let us see about the ventricular systole. The ventricular systole, it has two major events. One is isovolumetric contraction and the ejection phase. The two phases are the isovolumic contraction and ejection phase. The first you will see about the isovolumic contraction. Now the ventricles begins to contract. Sir, so Pushotman sir.
Sir, yes, sir. Tell me, sir.
Sir, I could be able to hear some interference, sir. I don't know who is on.
I will
whose mic is on.
sir.
Yes, sir. Thank you, sir.
Sir, நீங்க வீடியோ கொஞ்சம் ஆன் பண்ணிருங்க சார்.
Okay, sir. Okay, sir.
Yes. நீங்க அப்படியே அன்மியூட் பண்ணிட்டு வீடியோ ஆன் பண்ணி பேசுறீங்க சார். Yes.
Okay, sir. Thank you, sir.
Yeah, yes.
Okay, isovolumic contraction, it is the first stage in the ventricular systole. The isovolumic contraction, when the ventricles contract, the ventricular pressure increases above the atrial pressure. When the ventricle contract, the pressure in the ventricle increases above the pressure in the atrium. In the graph, you could be able to see the red line, that is the pressure of the ventricle. The ventricular pressure is increasing than that of the atrial pressure. So in order to prevent the backflow of blood from the ventricle into the atrium, the atrioventricular valves close. The tricuspid valve and the bicuspid valve closes simultaneously, and it prevents the backflow of blood from the ventricle into the atrium. So with the presence of blood in the ventricle begins to contract with the same volume of blood, that is a 130 ml of blood. The ventricles are contracting. This phase is called as isovolumic contraction because it is contracting with the same volume of blood, and there is no change in the metric, that is the length of the muscle fiber. So we can say it as isometric contraction. The isovolumic contraction can otherwise be said as isometric contraction. And the isovolumic contraction, it proceeds. Now we are going to discuss about the third pressure, that is the aortic pressure. You can able to see the another dotted line. The another dotted line which is present is called as aortic pressure. The aortic pressure, when the ventricles contract, the ventricular pressure increases above the aortic pressure. So the AV valves open. The aortic valve and the pulmonary valve opens. So this allows the blood from ventricle to the atrium. Sorry, aorta. Now we have come into the second stage of the ventricular systole. The ventricular systole, the ventricles are contracting. The ventricle pressure increases above the aortic pressure. So the AV valves, the aortic valves opens. This pushes the blood from the ventricle into the major vessel, that is the aorta and the pulmonary arteries. This increase in pressure pushes blood into the aorta and pulmonary vessels. And here you can see the aortic valve in the graph. The aortic valve is open. Now, with the contraction of the ventricular muscle, when you look at the graph, the red line, when the ventricle muscles are contracting, the pressure in the ventricle increases from 80 millimeters of mercury and to the 120 millimeters of mercury. So this ejection phase, it can be said as rapid ejection phase and slow ejection phase. Rapid ejection phase and slow ejection phase. When the AV valves open, the blood rushes from the ventricle into the aorta rapidly. That is the rapid ejection phase. The pressure increases from 80 millimeters of mercury to 120 millimeters of mercury in the ventricle. When we look at the aortic pressure, the aortic pressure also increases. The aortic pressure from 80 millimeters, it increases up to the 120 millimeters of mercury. This until this stage, it is called as a rapid ejection phase. So when the most of the blood is pumped from the ventricular pressure begins to fall. When the most of the blood from the ventricle are pumped from the ventricle into the aorta, the ventricular pressure begins to fall. You can also notice in the graph, the red line, from 120 millimeters, the pressure is declining in the ventricle. When the ventricular pressure falls below the aortic pressure, you can also notice the ventricular pressure is falling below the aortic pressure in the ejection phase, in the slow ejection phase. So let us see what happens in the next stage. With this, the ventricular systole is completed. Next, we move on with the ventricular diastole. The ventricular diastole, it has different phases, that is 5 phases: proto-diastole, isometric relaxation, rapid filling phase, slow filling phase, last rapid filling phase. So the duration of ventricular diastole is 0.5 seconds. You could also see in the graph the duration of diastole. The first 4 seconds coincides with the atrial diastole. The last 1 second, it coincides with the atrial systole. That is the last rapid filling phase. It coincides with the atrial systole. So let us see each phases in detail. First is the proto-diastole. The proto-diastole, it is a very short period in the cardiac cycle. It is a transition period. We can otherwise say the proto-diastole is a transition period. It is transition from the ventricular systole to the ventricular diastole. The ventricles are relaxing. The ventricles begins to relax. The ventricular pressure are decreasing. So when the ventricle pressure decreases, there will be backflow of blood from the aorta into the ventricle. In order to prevent the backflow of blood from the aorta into the ventricle, the aortic valve closes, that semilunar valve closes at the end of proto-diastole. So at the end of proto-diastole, the semilunar valve closes, which produces the second heart sound. The closure of semilunar valve produces the second heart sound. Okay, let us see about the isometric relaxation in the ventricular diastole. So I want to emphasize in the graph, in the you should watch the two things in the graph. One is the two graphs. One is the ventricular pressure. The ventricular pressure is decreasing. Then the aortic pressure. When the ventricular pressure decreases less than the aortic pressure, there will be chance of backflow of blood from the aorta into the ventricle. There is a chance of backflow of blood from the aorta into the ventricle. In order to prevent the backflow of blood, the aortic valve closes. The semilunar valves of the aorta and the pulmonary artery, those valves closes and prevent the backflow of blood. So at the end of the proto-diastole, the AV valve closes because the because the pressure in the ventricle is falling. The isometric relaxation. Now we are coming into the isometric relaxation. At present, in this stage, the 4 valves are closed. The 2 atrioventricular valves and 2 semilunar valves are closed. With the closure of 4 valves, the ventricle begins to relax. So this leads to there is no change in the volume of blood and no change in the ventricular muscle length. So this is called as isometric relaxation or isovolumic relaxation. And you should also note the volume change. The volume change in the ejection phase, initially it was 130. In the volume change, you can notice in the volume change at the end of the ventricular systole, the volume decreases to 50 ml. The volume is nearing to the 50 ml. This can be said as end systolic volume. This is called as end systolic volume. And 130 ml, it is called as end diastolic volume. That is during the end of ventricular diastole. So the end systolic volume is present here. With the end systolic volume, the 50 ml of blood present, the ventricles are relaxing. So it is called as isometric relaxation. This phase is called as isometric relaxation. Let us move with the next stage. Rapid filling phase. So the ventricles are relaxing. Now the AV valve, the ventricular pressure is falling down less than the atrial pressure. You can see here in the graph, the ventricular pressure, the red line has fallen below the atrial pressure. Because of that, the AV valve opens. It allows the blood from the atrium into the ventricle. So the flow of blood will be rapid. This rapid flow of blood from the atrium into the ventricle, this produces the third heart zone. The rapid flow of blood from the atrium into the ventricle due to opening of AV valve leads to production of third heart zone. So the next phase is slow filling phase. Now, the most of the blood, that is 70% of blood, is rapidly moved from the atrium into the ventricle in the rapid filling phase. Now, there is only a low volume of blood. Remaining 30% of blood is present in the atrium, and the blood is moving slowly from the atrium into the ventricle. So this phase can be said as slow filling phase. When we check the pressure of the atrium and the ventricle, there will be very less pressure in the atrium and ventricle. So this stage can otherwise be said as diastasis. This stage, the slow filling stage of the cardiac cycle, is called as diastasis. So let us move with the last stage of the cardiac cycle. The last is called as last rapid filling phase. So in the last rapid filling phase is otherwise called as atrial systole. Why we are calling it as atrial systole means the last rapid filling phase of the ventricular diastole, it coincides with the atrial systole. That is the atrial event, atrial systole. The atrium is contracting and the ventricles are relaxing. Due to the contraction of the atrium, the blood again rapidly moves from the atrium into the ventricle. So this phase is called as last rapid filling phase. Okay, and this last rapid filling phase due to contraction of the atrium will produce the fourth heart zone. So far, we have discussed about the pressure and volume changes during the cardiac cycle. So I'll summarize those events. Okay. The first you will see about the pressure change in the aorta. The aortic pressure, there is no much pressure change in the aortic pressure. It is maintained constant at a range of 80 to 120. We'll see at the last of the session how the aortic pressure is maintained at a range of 80 to 120, whereas the pressure in the ventricle, it falls to up to 5 millimeters of mercury and increasing up to 120 millimeters of mercury. How this happens in the ventricle and it is not happening in the aorta. The aortic pressure is maintained at a range of 80 to 120. Let us discuss later. The first, during the ventricular systole, sorry, the atrial systole, the pressure is somewhat nearer to 90 millimeters of mercury in the aorta, and at the end of atrial systole, the pressure nears to 80 millimeters of mercury in the isometric contraction, and the pressure when the AV valves, aortic valves opens, the rushing of blood from the ventricle, that is the left ventricle, into the aorta. So the aortic pressure increases from 80 millimeters to the 120 millimeters. And again, when the ventricular pressure falls, then the aortic pressure, the aortic valve closes, and there is a slight increase in the aortic pressure. There is a notch is formed in the aortic pressure, and it is a linear graph in the aortic pressure. So this is about the changes that takes place in the aortic pressure during the cardiac cycle. The next is the heart sounds. The heart sounds, there are 4 heart sounds. The first 2 sounds can be commonly heard in the for every individual. The third heart sound, it can only be heard in the athletes, and also for children it is heard. So let us see the causes for each heart sound. The first heart sound, it is produced by closure of atrioventricular valve, that is the tricuspid and bicuspid valve. The closure of the tricuspid and bicuspid valve produces the first heart sound, and the second heart sound is produced by the closure of a semilunar valve. This second heart sound is called as dub. The first heart sound is called as lub. And this is a second heart sound is a short and sharp sound, and it is produced by closure of aortic and the pulmonary valves. And the third heart sound, it is produced by a rapid flow of blood from the atrium into the ventricle in the rapid filling phase produces the third heart sound. It is not usually heard for normal individual. It can only be heard in the athletes and children. The fourth heart sound, it is produced by the contraction of the atrial muscles in the atrial systole. It also overlaps with the last rapid filling phase. So the 4 heart sounds, these are the 4 heart sounds. The graph what you are seeing here is a phonocardiogram. The phonocardiogram is nothing but a graphical recording of heart sound is called as phonocardiogram. With the help of the phonocardiogram, we can able to record the 4 heart sounds, first, second, third, and fourth. And now for normal individual, we can able to hear the first and second heart sound. And for athletes, we can able to hear the third heart sound. And the fourth heart sound, it is not audible. It can only be recorded with the help of phonocardiogram. Okay. The volume changes. We were talking about 2 volume. One is the end diastolic volume and end systolic volume. The end diastolic volume, the volume of end diastolic volume is 130 ml. That is present in the ventricle at the end of ventricular diastole. The 130 ml is present. After ventricular diastole, the ventricle begins to contract. You could be able to see the ventricle, the blue color. The ventricles are contracting. It sends the blood from the left ventricle to the aorta. So when the blood are emptied from the ventricle to the aorta, there will be only less amount of blood present in the ventricle. That is called as end systolic volume. So the 2 volumes we have, one end diastolic volume and another volume is called as end systolic volume. At the end of systole, the blood is pumped from the ventricle to the aorta. That is called as end systolic volume. So the difference between the end diastolic volume and the end systolic volume is called as stroke volume. When we subtract from the end diastolic volume with the end systolic volume, we get the stroke volume. That is the definition for stroke volume is the amount of blood ejected from each ventricle per beat is called as the stroke volume. During every cardiac cycle, the certain amount of blood is pumped out of the cardiac from the heart for every beat is called as a stroke volume. That is the difference between the end diastolic volume and end systolic volume. So now we have came into the last part of the session. The Ventricular effect. The Ventricular effect, when the ventricles contract, the first during the systole, when the ventricles contract, the blood is pumped from the ventricle, left ventricle to the major artery, that is the aorta. And during the diastole, there is no pumping of blood or movement of blood take place. Actually, there won't be any movement should take place in the aorta, but there will be certain, there is a movement is taking place in the aorta with the compression of aorta is taking place. This pushes the blood from the aorta into the peripheral circulation to the peripheral capillaries. I am playing a video. With the help of that video, you could be able to understand the Ventricular effect. Okay.
To speak.
So in this video, you could be able to see there is a flow of blood water from the tube. We consider the tube as aorta. The flow is intermittent. When the ventricles contract during systole, the blood is pumped to the aorta, and during the diastole, it actually there should be no flow of blood from the through the aorta. But actually, what happens in a human being is when the ventricles are dilating, still there is a flow of blood in the aorta. This is due to Ventricular effect. The Ventricular effect is when the ventricle contract, the 80 ml of blood, the certain volume of blood is stored in the aorta. The balloon, what you are seeing here is the aorta. During systole, the blood is stored in the aorta, and during diastole, the aorta contracts again, and it leads to the continuous flow of blood in the circulation. So this Ventricular effect helps in continuous flow of blood during the ventricular diastole. So because of this, the Ventricular effect, we could be able to maintain the aortic pressure or peripheral circulation pressure at a range of 80 to 120. Sorry, we can otherwise say the peripheral pressure is maintained at 120 by 80. When we are measuring the blood pressure, the systolic pressure we are getting 120 and diastolic pressure 80. Why the diastolic pressure is not falling below 80 millimeters of mercury means this is due to the Ventricular effect. This Ventricular effect, due to contraction of the aorta, the pressure is maintained at 80. When we check the pressure of the ventricle, the left ventricle, the pressure ranges from 5 millimeters of mercury to 120 millimeters of mercury, whereas in the pressure of the aorta, the pressure is maintained at 80 to 120. So the peripheral pressure is maintained at a range of the maximum pressure is 120 and minimum pressure is 80 with the help of the Ventricular effect also plays a role in maintaining the peripheral blood pressure at a range of 120 to 80. So, okay, with this, I complete my session. Once again, I thank the organizers for organizing such an event, which will be beneficial for the first years. And Thank you, sir.
Thank you, sir.
Thank you.
Thank you so much, sir. Wonderful presentation, sir, with a very good examples. Your presentation. Thank you so much, sir.
Thank you. Thank you, everyone. Thank you for everyone for patient listening.
Yes, sir. Is there any doubts from the students' side? Is there any doubts from the student side? You can post your questions through the chat box. It will be informed to the speakers. No doubts. Yeah, thank you, sir. Thank you for being with us, sir. Yeah, thank you, sir. Thank you so much, sir. The next presentation is by me. I am Dr. G. Purushothaman from Vivekananda Dental College. I am going to present the topic on ECG. Yes, good morning to all. Today I am going to present the topic on ECG. ECG is electrocardiogram. Okay. Exam oriented, I'll be explaining little more detail about ECG. At the end of this session, you must know about what is ECG and its importance, what is electrophysiology of ECG, what are the waves of ECG and its causes, what are the segments and intervals, how will you record an ECG, what are unipolar and bipolar leads, and how will you calculate with the help of an ECG strips, heart rate. How can we calculate the heart rate with the help of an ECG? First, ECG. ECG is nothing but electrocardiogram. Okay. In ECG, you have to know three different terms that you may be confused with these terms. Number one is electrocardiography, electrocardiogram, and electrocardiograph. First, electrocardiography. Electrocardiography is the technique. With the help of this technique, you have to know about these terms always. ECG is nothing but electrical activity of the heart. See, you have to know the difference between a ECG, electrocardiograph, cardiogram, and cardiography. Graphy is a technique. In this technique, you are going to record or even measure about the electrical activity of the heart. And electrocardiogram, the name itself, the gram, is nothing but a graphical representation of the electrical activity of the heart. Okay. Next one is electrocardiograph. Electrocardiograph is an instrument that can be used to record the electrical activity of the heart. The electrical activity of the heart, the term that you have to use for ECG. Yes, not only on even the gram, the name is represented in all this time. See here, even in phonocardiogram, spirogram, myogram, and encephalogram, all these things are graphical representation of your activities. Phonocardiogram is about the pulse activity, and even spirogram is about the respiration, myogram your muscle activity, encephalogram and about your EEG. Apart from this one, you are having angiogram, urogram, and mammogram. All these are all imaging technique with the help of an X-rays. Right. Next one. There are some basic principles that you have to know about an ECG. How the ECG is recorded. A small electrical changes that has been generated by the heart that goes up to your myocardium. With a suitable of electrode, with the help of suitable electrode, you can record the electrical impulses that is coming out from the ECG. First one, these electrical impulse. Suppose if you are placing an electrode, if the electrical impulse flows towards the unipolar electrode, that shows a positive reflection. Not only an unipolar, even a bipolar electrode. If the electrical impulses flows towards your positive peak. Okay, now listen here. If the electrical impulse moves towards the towards the unipolar electrode, shows a positive peak, and at the same time, if in the bipolar leads, if it is moves towards the positive electrode, it shows a positive reflection. The same way, if the electrical activity, the electrical impulse moves against the unipolar electrode or moves towards the negative electrode, it shows a negative deflections. See here.
பத்தாது சரியா இருக்கா பத்தாதுடா
Okay, see here now, if the electrical impulse it moves towards this electrode, it shows a positive deflection, and at the same time, if the electrical impulse are away from the electrode, it shows a negative deflection. This is the basic things that you need to know in ECG, in recording of ECG. See here, the same way, it shows a positive thing, and if it is moves away from the electrode or negative electrode, it shows a negative deflection. Okay, in ECG, you have to know about a few terms that you have to remember. In a cardiac cycle, what you have to mention, a systole or diastole. In another word, simple term is contraction and relaxation. Contraction, it's nothing but a systole. Relaxation is nothing but diastole. The same way, we use the normal term contraction and relaxation. Here we have to use depolarization and repolarization. Depolarization is nothing but a contraction. Repolarization is nothing but relaxation. Okay, now see, this is the basic things, schematic diagram with the help of a cardiac cycle. Listen here. See the circle in a circulatory system. You have to know the circulatory system. See here, it's starting from the left atrium. Okay, circle is nothing but a starting and ending point will be the same. Yes, it's starting from the left atrium. See, it's starting from the left atrium, then it reaches to the left ventricle. Okay, once it moves from the chamber, there is some valve will be there, that is called as bicuspid valve. That valve, it allows the blood flow only in one direction. Once the blood it move from the left atrium to the left ventricle, then it will goes to your systemic circulation through your another one more valve. See, if the blood is emerges out from the left ventricle, there is some one more valve that is called as aortic valve. From the aortic valve, it will reaches to your systemic circulation. From there, it will reaches to your right atrium. From the right atrium, it will reaches to your right ventricle. See, again here, from the valve, it will be emerges out from or leaving out from this valve to the another valve, another chamber. There is some one more valve that is called as tricuspid valve. From the right atrium to the right ventricle, then it will comes out from the right ventricle. There is one more valve, it is called as pulmonary valve. Then it will goes to your pulmonary circulation. Again, it comes back to the left atrium. See, this is called as a circulation. Circulation is starting and ending point will be the same. See, from the left atrium, it will go to all the way to your systemic circulation. Again, it will come back to your pulmonary circulation and left atrium only. That's why it is called as circulatory system. See, in the schematic diagram, konja draw panni vechukonga. It will be helpful in your examination purpose. In that way, you can write your cardiac cycle schematic way. Okay, now William Einthoven is a Dutch physiologist. He developed the technique of ECG. He awarded with the Nobel Prize in the year 1924 for his invention. He is a father of modern electrophysiology. Okay, now basic concepts of ECG here. See, yes, small stimulus is given to a muscle. Listen here. First, you have to know about what you mean by resting membrane potential. If any stimulus given to your resting membrane potential, it will change the resting membrane potential. That is called as action potential. See, frequent you will be asked the questions, what do you mean by action potential? Action potential, a simple term. Easy or vival question answer you have to mention like that. What do you mean by action potential? Action potential is nothing but a small changes in the resting membrane potential when a small stimulus is given. See, this is the term. You note it down. See, a small changes in the resting membrane potential is called as action potential whenever a stimulus is given to the muscles. Yes, the same way from your SA node to an AV node. SA node is a pacemaker potential. From there, your pacemaker potential, your potential will start from here. Then SA node to an AV node, the atrium will contract. Next here, see here, from atrium will contract. From AV node to, it will reaches to your ventricle. Again, it will contract from the ventricle. Same way, it will relax. So contraction and relaxation will occur here from the SA node to an AV node. We'll see one by one the steps. Okay, now see, the electrical current is now generated by the heart from the SA node. Now it reaches to the AV node. The same way, a conduction, it reaches throughout the body. Later, it reaches the skin. With the help of a suitable electrode, it will be recorded in your electrocardiograph. See, the electrocardiograph is nothing but it's an instrument that is used to record the electrical activity of the heart. Now, see, always remember this thing. Listen here. If the electrical impulse flows towards your electrode, if your electrode is placing here, if the electrical impulse moves towards your electrode, it shows a positive deflection. If the electrical impulse are move away from the electrode, it shows a negative deflection. Am I clear? Okay, now another important term you have to know about is depolarization and repolarization. Depolarization is nothing but a contraction or even a systole. Repolarization is nothing but relaxation or diastole. In a ECG, we have to use this term depolarization and repolarization. But a mechanical term is contraction and relaxation. In cardiac cycle, we have to use systole and diastole. Listen now. A resting state or totally polarized state, that is a resting membrane potential whenever a small stimulus is given there, that is from the SA node, that is a pacemaker potential. Whenever the stimulus is given here, what happened? It produces an action potential. The small changes in the resting membrane potential is called as action potential. So the depolarization will occur. See, after the depolarization, after the contraction, there will be some relaxation. Okay, now this is about the ECG strips. See here, this is one small square. Listen here, this is one small square is 0.04 seconds. Yes, and this is one medium square and this is one large square. Am I clear here? This is 1 centimeter large square. See, in a graph, already you know about that. Once you are drawing a graph or even we call it as, the term is gram here. In a graph, the known values will always be taken in x-axis. With the help of a dependent x value, if you are finding some other value, that will be placed in unknown value, that will be placed in y-axis. Here we know about the timings. What is the cardiac cycle timing? That will be around 0.8 seconds. Yes, but we don't know how much stimulus is producing, how much the electrical impulse is producing, that we don't know. So known value will be given in x-axis, unknown value will be always placed in y-axis. That means it is dependent on x-axis only. Listen here, there is some scale here. See, again the same. See, in 1 second, one full cardiac cycle event will be over. See here, this is one small square, 0.04 second. that is one small box is equal to 0.04 second. 5 small box, that is 0.2 second. That is one large box is 0.2 second. Total pathina 1 minute 5 boxes varum. That means 25 millimeter. So one box மட்டுமே பாத்தீங்கன்னா 1 millimeter. Am I clear? இங்க பாத்தீங்கன்னா 5 millimeters one boxes. Total பாத்தீங்கன்னா 5 boxes பார்க்கும்போது 25 millimeter இருக்கும். That is the 25 millimeter per second the strip will move. Normally 25 millimeter per second. In that way your ECG strips will move. See here, in 1 second your ECG will move. That means in 1 second one cardiac cycle will be recorded. Not even 1 second, it is 0.8 second one full cardiac cycle. That means 4 boxes. See here, R to R, 1 R is in between 1 R to another R, that is called as heart rate. One full cardiac cycle, nothing but heart rate is nothing but one cardiac cycle. In a minute அப்படினு பாக்கும்போது ஒரு நிமிஷத்துல எத்தனை முறை ஹார்ட் வந்து கண்ட்ராக்ட் ஆகிட்டு ரிலாக்ஸ் ஆகுது. That means heart rate. Am I clear? If you are having any doubts, you just post me in a chat box, or even you can raise your hand and ask me your doubts. Okay, now see, this is about the scale. ECG is recorded on mm square, millimeter square graph, moving at the speed of 25 mm per second. Okay, in x-axis represents 1 millimeter, that is equal to 0.04 second. Yes, and y-axis represents a voltage. 1 millimeter is equal to 0.1 millivolt. See, y-axis la vandu unknown factor evlo varundradha namakku theriyadu. Based on that, your contraction of your heart and your values, that means the potential created by your heart, will vary. X-axis la vandu it's a known value, that is a time 0.8 seconds one cardiac cycle அப்படின்றது நமக்கு தெரியும். So 1 second க்கு மூவ் ஆகுற மாதிரி நம்ம ECG steps மூவ் பண்ணிட்டு இருக்கோம். Listen here, the same point, remember always, any deflection of record above the baseline, that is isoelectric point. This one is isoelectric point. Above the deflection is positive, below the isoelectric point is negative. Am I clear? Again, see here, now 1 second above a positive deflection and below isoelectric point is negative deflections. Okay. What are the uses of ECG? ECG uses enna? Clinical ECG is a valuable tool to diagnose the following, that is a cardiac arrhythmia, conduction defects, ischemia, or even infraction of the myocardium, and chamber enlargement, and electrolytic imbalance, and coronary heart disease. Idella diagnose pandradhukku we have to first use the ECG and your heart rate and your heart rhythm. Okay, I will tell you at the end, with the help of an ECG, how can you calculate manually the heart rate. Okay, and small tips I will tell you, it will be helpful to find the defects. Yes, I will tell you one by one. Okay, now this is about the electrocardiogram. Again, I will repeat you the same. Gram is nothing but a graphical representation. The graphical representation of electrical activity of the heart. See, this is 1 second, one full cardiac cycle. See here, 0.8 seconds, one full cardiac cycle will be over. Next 0.8 seconds, another cardiac cycle. Then R to R interval means it's an interval between one cardiac cycle to the another cardiac cycle. Okay, now how will you record an ECG? There is a procedure to record an ECG, that is called as electrocardiogram. In that way, your electrocardiograph, here your ECG strip will move 25 millimeter per second, and See here, in some other cases, in case of hypertension, it will be moved for 50 millimeter per second. So it will be recorded in two ways. One is a unipolar method, another one is bipolar method. We'll see one by one in detail. Okay, now listen here. This is about an ECG recording machine. There are 12 leads that can be used to record your electrical activity of the heart. One is bipolar lead, and another two is unipolar lead. And this is one one triangle. Frequent உங்களுக்கு வந்து வைவால கேக்குற questions வந்து one triangle and one law. What do you mean by one law? First, in a volume conductor. Listen carefully. இது வந்து frequent கேக்குற ஒரு questions. வைவால கேக்குற ஒரு questions. See here, in a volume conductor, the sum of the potential at the end of one equilateral triangle with the current source in the center, it will be always zero. See, the sum of the potential at the end of these three triangle, the potential at the center will be zero. See, the same similar equilateral triangle can be produced in our body by placing or connecting the electrode on right arm, left arm, and left leg with a current source at the center. Imagine that your heart will be at the center in the imaginary triangle. So it produces the current at the center is zero. Am I clear? Simpler சொல்லணும் அப்படின்னு பாத்தீங்கன்னா, the one triangle வந்து modified one law அப்படின்னு பாத்தீங்கன்னா, that is called as Kirchhoff law. Kirchhoff law ல என்ன சொல்றாங்க அப்படின்னு பாத்தீங்கன்னா, the arithmetic sum of the potentials of all the leads. Imagine the heart will be at the center, the potential will be equal to zero. Listen here, the sum of the potential from the lead 1, lead 2, and lead 3 all add together. It produces the potential that is equal to zero. Am I clear? Is there any doubt? You can ask me in between. Okay, now first one is bipolar leads. Recording your bipolar leads. ECG recording using two active electrode. Yes, in this active electrode, one will be placing in one limb, another will be placing in another limb. In that, one is an active electrode, another one is a reference electrode. Listen here, in the lead 1, there are three leads, lead 1, lead 2, and lead 3. See here, the lead 1, it's connecting between your right arm and to the left arm. The negative potential of your left lead 1 is connected to your right arm, and the positive potential is connected to your left arm. That is produce a lead 1, and at the same time the negative electrode is connected to your right arm and positive electrode is connected to your left leg. That produce lead 2. Yes, see, imagine the bipolar electrode. One electrode is connected to your right arm to the left arm, and right arm to the left leg, and third electrode is connected in between your left arm to the left leg. This produce an imaginary equilateral triangle, and assume that our heart will be at the center. This produce an equilateral triangle is called as one triangle. See here, usually pathina negative to positive, the electron will always move towards the positive side. அதுதான் உங்களுக்கு வந்து கரண்டோட டைரக்ஷன் இங்க காமிக்கறாங்க. So negative to positive, this is positive. Am I clear? This is positive lead 1. இந்த சைடும் பாத்தீங்கன்னா it's positive lead 2. இந்த சைடு வரும்போது இது ஆப்போசிட் டைரக்ஷன்ல இருக்கு. That means a negative lead 1 plus lead 2 minus lead 3 minus lead 2, that is equal to 0. இதுதான் வந்து modified one law is called as Kirchhoff law. Okay, now how the lead 1 is produced. Listen carefully. The positive terminal is connected to the left arm and the negative terminal is connected to your right arm. This constitutes lead 1. See, lead 1 oda ECG curve இப்படிதான் இருக்கு. ஓகேங்களா? Next one, lead 2. Listen here, listen carefully. Usually நம்ம ECG record பண்றது எல்லாமே lead 2 ல தான். Lead 2 ல positive terminal is connected to your left leg. See here, positive terminal is connected to your left leg and negative terminal is connected to your right arm. This constitutes lead 2. This way, this is the direction. Am I clear? Listen carefully. I will explain a small concept, that a basic concept here. See, this is a negative potential and this is a positive potential. During ECG contraction, that means heart contraction from your right atrium to your right ventricle or your left atrium to your left ventricle. So during contraction of your right atrium, the blood move towards your positive ventricle. See here, the blood will move from your left atrium to your left ventricle, and at the same time, this is the consecutive events. That means successive events, nothing but once your right atrium contracts, the same way left atrium will also contract. Then all the blood from your left and right atrium it reaches to your ventricle. The same way, both left and right ventricle will contract. From your right atrium, it will go to your pulmonary circulation. From the left atrium, it will go to your systemic circulation. Okay, now listen here. This is about a lead 3. Lead 3 is connected by your left lead is your left electrode is connected to your left arm and right electrode. See, positive electrode is connected to your left leg. It constitutes lead 3. Yes. Okay, now this is your bipolar leads, and this is one is eighth one law. இதை ஞாபகம் வச்சுக்கோங்க. frequent-ஆ உங்களுக்கு வந்து viva questions கேட்பாங்க, and even 2 mark questions frequent-ஆ கேட்கிற questions. If the electrical potential of any two of 3 bipolar leads, see இங்க lead 1, lead 2, lead 3 3 இருக்கு. இதுல வந்து என்னன்னா ரெண்டோட values தெரிஞ்சதுன்னா third one வந்து ஈஸியா calculate பண்ணிடலாம். That is called as eighth one law. If the electrical potential in a volume conductor, அது மட்டும் ஞாபகம் வச்சுக்கோங்க. In a volume conductor, the electrical potential is generated by the heart. The potential of 2 or 3 bipolar leads are known at a given instant. The third one can be determined by summing of first two. எதனா ரெண்டு ஆட் பண்ணீங்க அப்படின்னா third one calculate பண்ணிடலாம். மூணுமே ஆட் பண்ணோம் அப்படின்னு சொன்னீங்கன்னா the final summation of all the 3 electrode potential is equal to 0. Okay, now what do you mean by unipolar electrode? Here in unipolar electrode you have 2 electrode. One is an active electrode, another one be indifferent electrode. Indifferent electrode will always keep a 0 potential. Yes, listen here, one is an active electrode, another one is an indifferent electrode. Indifferent electrode is always connected to a 0 potential. So whatever the potential is generated, that can be received by your active electrode. Yes, any doubts? Anunandan, Anunath and Darshini. Any doubts? Okay, let me start. Okay, now this is about first one is unipolar limb leads, and this one is unipolar chest leads. Unipolar limb leads pathina, there is a 3 lead. Unipolar chest lead is 6 leads, totally 9 leads, and your bipolar leads are 3, totally 12 leads. With the help of these 12 leads, we can record your electrical activity of the heart. Okay, now this is your pericardial leads, chest leads. There are 6 leads: V1, V2, V3, V4, V5, and V6. V1 is, see here, the V1, that chest lead is placed in your 4th intercostal space, the left sternum border. See here, V1 is in a right sternum border and V2 is left sternum border. Listen carefully. V1, the 4th intercostal space, 3 and 4, 4th intercostal space to the right sternum border. V2 will be placed in the left sternum border. V3 we'll see later. And V4 is in between same 5th intercostal space that rise in between mid clavicular line. ஒரு மிட் கிளாவிக்கல்ல இருந்து ஒரு இமேஜினரி லைன் டிரா பண்ணீங்க அப்படின்னா 5th intercostal space அந்த இடத்துல எங்க ஜாயின் ஆகுது அப்படின்னு பாத்தீங்கன்னா in that way you have to place the electrode V4 and V3 வந்து பாத்தீங்கன்னா it will be in between V2 and V4 சிம்பிளா பாத்தீங்கன்னா நிப்பிளுக்கு கீழே வரும் that is V3 ஓகேங்களா இந்த 4th sternum மேல இருக்கும் and V6 is anti axillary okay anterior axillary line la V6 present ஆயிருக்கும் and mid axillary line of 5th intercostal space you have to place your 6th lead. All these leads are chest leads. We'll see one by one. See here, listen carefully. See, these are all representing your QRS complex. Have to mention about this one. I have forgot this one. Listen here. This is your ECG. See, this is your ECG second step. Here, what are the constituents of ECG? They may ask you what are the constituents of ECG. T, QRS complex and T wave. இதுதான் நீங்க மென்ஷன் பண்ணுங்க ECG ல what are the constituents of ECG அப்படின்னு கேட்கும்போது PQRS காம்ப்ளெக்ஸ் அது எல்லாமே மென்ஷன் பண்ணணும் சரிங்களா ஃபர்ஸ்ட் இந்த P wave எப்படி வருது யூசுவலா பாத்தீங்கன்னா see listen carefully atrium contracts இது வந்து ஒரு கான்சிக்யூட்டட் ஈவென்ட்ஸ் அப்படின்னு சொல்லும்போது ஏட்ரியம் கண்ட்ராக்ட் ஆகும்போது and at the same time your ventricle get relaxing see here atrium will contract and at the same time your ventricle gets relaxing atrial contraction and ventricular relaxation. Next events, once the ventricle starts contracting and at the same time your atrium will relaxing here. Am I clear? First one, the ECG la first segment அப்படினு பாக்கும்போது even in a cardiac cycle la கூட பாத்தீங்கன்னா cardiac cycle first segment is your atrium contraction. Once the atrium starts contracting, இங்க atrium contract ஆகும்போது listen here, atrium contract ஆகுதுன்னா from this side. Am I clear? So the blood will rushing from the atrium to your ventricle. The blood flow will move from the atrium to the ventricle. See here, the same way your potential will start from the atrium to the ventricle. As we know, the basic principle of ECG is once the potential moves towards the positive side of an electrode, it shows a positive deflection. Am I clear? It shows a positive deflection. So atrium contract ஆகும்போது potential எல்லாமே it moves towards your positive peak. So it shows a positive deflection, that is P wave. And QRS complex அப்படின்னு பாத்தீங்கன்னா ventricular contraction or ventricular depolarization அப்படின்னு சொல்லுவாங்க. See, cardiac cycle la ventricular systole சொல்லுவோம், mechanical event பாத்தீங்கன்னா ventricular contraction சொல்லுவோம், and ECG la ventricular depolarization. Ventricular depolarization ventricle contract ஆகுது. Am I clear? Once a ventricle starts contracting, ventricle contract ஆகும்போது என்ன ஆகும்னு பாத்தீங்கன்னா see here, a small Q wave என்ன ஆகும்னா small Q wave deflect ஆகும் and later it will shows a positive deflection. And once the ventricle starts relaxing, ventricular repolarization ஆகும்போது என்ன ஆகும் பாத்தீங்கன்னா again the same way your potential is moved towards the positive, it shows a T wave. See, P QRS complex and T wave. P wave பாத்தீங்கன்னா atrial contraction, QRX பாத்தீங்கன்னா ventricular contraction and T wave வந்து ventricular relaxation. அப்ப ஏட்ரியத்தோட relaxation, atrium repolarization எங்க இருக்கும் அப்படின்னு பாத்தீங்கன்னா இந்த QRS காம்ப்ளெக்ஸோட மெர்ஜ் ஆயிடும். Okay, now see, listen here. See this one, V3 and V4. V3 and V4, see here, we are placing the electrode V3 and V4. Heart will be at the center. Am I clear? Now listen here, V3, here QRS complex. See, once the atrium starts contracting, atrium contract ஆகும்போது you are placing your electrode here. See here, in the points புரியுதா பாருங்க. Contract ஆகும்போது it shows a positive deflection. ஓகேங்களா? Then relax ஆகும்போது ventricular contract ஆகுது. See here, ventricular contract ஆகும்போது positive deflection வருது. One left ventricle relax ஆகும்போது என்ன ஆகும் பாத்தீங்கன்னா the blood relaxation appo contract ஆகும்போது move ஆயிரும் and relax ஆகும்போது against it will move in this direction. It will shows a negative deflection. Am I clear? இது புரியுதா பாருங்க. Contraction and relaxation. See, you are placing the electrode here. During contraction ஆகும்போது, that means the electrical impulses are moving towards your V5 and V6. It shows a positive deflection. If it is moves away, ஓகேங்களா, the small peak இங்க இருக்கும். This is a consecutive events. First கொஞ்சம் relax ஆகி next தான் இது contract ஆக ஆரம்பிக்கும். Relax ஆகும்போது a small negative peak. அது contract ஆகும்போது so it will shows a maximum positive peak. Am I clear? என்ன doubt இருந்ததுன்னா கேளுங்க. Any doubts? The same one, see here, V3. Yes, V3, same here. Atrial contract ஆகுது. Contract ஆகும்போது positive deflection. See here, V3 பாத்தீங்கன்னா உங்களுக்கு தெரியும். Positive deflections வந்து contract ஆகும்போது. Next, relax ஆகுது அப்படின்னும் போது the blood rushing towards your aorta. Aortaக்கு move ஆகும்போது என்ன ஆகுனா against the electrode. Electrodeக்கு against move ஆகிறதுனால negative deflections காட்டுது. The same way all the electrodes are placed like this. The potential moves towards the electrode positive. If the potential moves against the electrode, it shows negative. Am I clear? Next one, unipolar lymph leads. Unipolar lymph leads அப்படின்னா என்னன்னு பாத்தீங்கன்னா AVR, AVL and AVF. That means augmented அப்படின்னு சொல்லுவாங்க. Augmented is nothing but AVL. For example, in case of AVL அப்படின்னு பாத்தீங்கன்னா இது ஒண்ணுத்துக்கு மட்டும் active electrode வச்சுட்டு in another two, if AVL னா left arm வச்சிட்டீங்கன்னா right armum left legum that will be connected to your zero potential அப்படி இல்லனா high resistance ஓட connect பண்ணிடுவாங்க. அப்ப connect பண்ணிட்டாங்கன்னா the only one will be active, remainings are not active. That will be given a zero potential. See, the active electrode is connected to one of the limb and the indifferent electrode is obtained by connecting the other two limbs through a high resistance. High resistance அப்படினு சொல்லும்போது potential will be very less. Am I clear? Listen here, this is the AVL. Active electrode is from the left arm and the indifferent electrode is connecting by the right arm and left leg. The same one, augmented அப்படின்னும் போது strengthening பண்றாங்க. Strengthening பண்ணிட்டு see AVR அப்படின்னு பாத்தீங்கன்னா இந்த ரெண்டு லிம்பும் ஓகேங்களா, your left leg and your left arm ரெண்டுமே கனெக்ட் பண்ணிட்டு அதுக்கு high resistance கொடுத்தாங்கன்னா no potential, so this one only will be active. That is called as augmented lymph leads. Here, this is about the peaks of AVR, AVL and AVF. Okay. What are the waves of ECG? This one. First, what I told, the same one. The electrical activity of various parts of your heart tissue during each cardiac cycle. Each cardiac cycle, what are the components of ECG? You have to mention all these things. What are the components of ECG? PQRS, D, and U wave. U wave will be rarely appear with the help of your papillary muscles. Okay, now. So usually pacemaker potential from your SA node. Okay, depolarization will initiate from the SA node. That is called as from the SA node to an AV node. Once your potential it reaches to your AV node, the same way your atrium starts contract. Once the atrium starts atrium contract ஆகும்போது here இது வந்து lead 2. இத கொஞ்சம் listen பண்ணுங்க. Listen here. Atrium starts contract. Once the potential reaches from the SA node to an AV node, atrium starts contracting. Here you are placing your leads. This is a negative and this side is positive. ஓகேங்களா, இதுதான் உங்க second lead சொல்றோம் இல்லையா. Bipolar leads, this is a negative and this one is a positive. Here your positive electrodes are there. All the potential now reaches from the AV node to SA node to an AV node. So it moves towards your positive peak. It shows a positive deflection. Yes, that is atrial depolarization. Mechanical event atrial contraction. Cardiac cycle we call it as atrial systole. Okay, the duration of atrial systole is very less, 0.1 second. Okay, that means 4 boxes, just 3 small boxes. Listen here, this is the one. Atrium contract or lead 2 la pathina. See here, it moves towards the positive peak. It shows a positive deflection. Now, AV node depolarization. Inga the AV node depolarization start panadhu appdin pathina. Now the contraction of your ventricle. See, first ventricle vandu konja relax aayittu atrium contract agumbodhu, and at the same time there will be some ventricular relaxation. Seringla ventricular relaxation irukumbodhu some negative deflection vandittu, next you are having a positive deflection by contraction of your ventricle. Okay, so your potentials are moving towards in this direction. SA node to AV node. AV node length your bundle of histidine vadiya reach agumbodhu the potentials are moving in this way. Okay, in the direction la move agumbodhu it shows a maximum positive deflections. Next, ventricular relaxation agumbodhu mattum there is some positive deflection here. Okay, this is the thing, you are getting a positive deflections. Okay, now this is about your R wave, R and S wave. The same way, R is represent the excitation process by suddenly invading both ventricles, that is interventricular apex and major portion of your both the ventricles. Once both the ventricles starts contract, it produce an R wave. The same one S wave epa varum appdin pathina. S wave represents the excitation of more basal part of your ventricle. Basal part appdin pathina ventricle see, from this side basal part length vandu pathina ventricle from this direction it starts contracting. Okay, now next one, see here ventricular repolarization. See, repolarization of your ventricle again. Once the ventricle starts contracting towards, relaxing towards here, it shows again a positive deflections. Okay, T wave around a positive deflection reference the ventricle produce a repolarization. Its times about 0.27 seconds. And see here, isoelectric point la pathina, isoelectric appdin pathina, this is the line isoelectric point. The T wave sometimes spends very less amount, 0.04 second. And here U wave is represents the repolarization of your capillary muscle. This is rarely occur, not all the time. Okay. Okay, this one PR segment, ST segment. Listen here, PR segment is in between this way. See, all these segments are present only in the isoelectric line. Isoelectric line la irukra segments mattum da ungalku PR segment, ST segment varum. See here, PR segment appdin pathina from the ending of P wave to the onset of Q wave. In the rendu point irukku illinga, this is called as an PR segment. ST segment appdin pathina ending of S wave to your onset of P wave. In the segment da ST segment. இதனோட யூசஸ் என்ன அப்படின்றத பின்னாடி பார்க்கலாம். ஃபர்ஸ்ட் ஒன் PR interval. PR interval அப்படின்னு பாத்தீங்கன்னா it's onset of P wave to the ending of your onset of your QRS complex. This PR interval is mainly depend on your atrial contraction. See, for example, usually ஒரு normal duration அப்படின்னு பார்க்கும்போது 0.13 ல இருந்து 0.16 seconds மட்டும் தான் இருக்கும். அதாவது 4 small boxes மட்டும் தான் இருக்கும் இங்க. Suppose is there any defect in your atrium? Atriumல வந்து எதனா ஒரு defect இருக்கு, conduction defect இருக்கு அப்படின்னு பாத்தீங்கன்னா there will be a value changes. ஒழுங்கா ப்ராப்பரா கண்டக்ட் ஆகல அப்படின்னு பாத்தீங்கன்னா the duration வந்து கொஞ்சம் extend ஆகும். Am I clear? இந்த கான்செப்ட் புரியுதா பாருங்க. இந்த ECG வந்து எப்படி மெஷர் பண்றாங்க, how they are used for diagnostic purpose அப்படின்னு பாத்தீங்கன்னா if there is any conduction defect, SA node la the AB node வந்து conduction defect சரியா reach ஆகலனா atrium will not contract. atrium ஒழுங்கா conduct பண்ணல, that means depolarization நடக்கல அப்படினு பாத்தீங்கன்னா, see here usually பாத்தீங்கன்னா 0.13 ல இருந்து 0.16 second is the normal duration for your PR interval, that is atrial contraction. ஒழுங்கா கண்டக்ட் பண்ணல அப்படின்னு பாத்தீங்கன்னா இந்த டியூரேஷன் எக்ஸ்டெண்ட் ஆகும். டியூரேஷன் எக்ஸ்டெண்ட் ஆச்சு அப்படின்னா we can diagnose that there is some problem in your atrium. The same way, even for example in case of enlargement of your chamber, usually பாத்தீங்கன்னா ventricle chamber வந்து enlarge ஆகும். listen carefully, ventricle chamber வந்து enlarge ஆகும், கேள்விப்பட்டிருக்கீங்களா? enlargement of your ventricle chamber. இப்ப ventricular contraction எங்க நடக்குது? ventricular contraction is happening, that means nothing but ventricular depolarization. It's starting from QRS complex. This QRS complex is nothing but your ventricular contraction. So ventricular contraction அது எதை மெயின் பண்ணி இருக்கும்னு பாத்தீங்கன்னா Q to T interval. Listen here, the Q க்கு T interval, Q to T interval na onset of Q wave to your onset of T wave, that is the QT interval. This is completely main depends on your ventricular contraction. இதனோட duration என்ன இருக்கும் அப்படின்னு பாத்தீங்கன்னா, its duration is 0.4 seconds up to 0.43 seconds தான். enlargement அதிகமா இருக்கு, if your ventricle is more enlarged, அந்த ventricular chamber வந்து ரொம்ப பெருசா இருக்கு அப்படின்னு பாத்தீங்கன்னா அது contraction timing கொஞ்சம் அதிகமா இருக்கும். இப்போ contraction time is more அப்படின்னு பார்க்கும்போது இந்த QT interval வந்து கொஞ்சம் extend ஆகும். 0.4 இல்லாம இன்னும் ஒரு 0.5 0.6 அப்படி இருந்ததுன்னா you can mention that, you can diagnose that there is some problem in your ventricle. ஓகேங்களா? not only on this, even there is some myocardial infarction. Myocardial infarction in the myocardium muscles இருக்கு இல்லையா? is there any defect on your myocardium அப்படின்னு பார்த்தீங்கன்னா myocardium la enna defect irukku appdin pathina unga QT interval vandu it will be prolonged. With the help of prolong, it can be used for the diagnostic purpose for your improper functioning of your heart. Am I clear? The same way your ST segment, this ST segment, ST interval is mainly on your the same ventricle repolarization. enna or problem irukku appdin paakumbodhu இந்த QT interval and ST interval odia gap mention பண்ணி you can define. Next one, how will you calculate your heart rate? heart rate வந்து எப்படி calculate பண்ணலாம்? manually எப்படி calculate? usually பாத்தீங்கன்னா in ECG machine that will be automatically calculate your heart rate and it will show. now இப்ப manually ஒரு ECG கொடுத்துட்டு heart rate என்ன எப்படி calculate பண்ணீங்க அப்படின்னு பாத்தீங்கன்னா first you have to find the time interval between one hour to your next hour. That means ஒரு cardiac cycle க்கும் இன்னொரு cardiac cycle க்கும் இடையில இருக்கிற time interval எவ்வளவு அப்படின்னு calculate பண்ணீங்கன்னா you can easily measure your heart rate. heart rate எவ்வளவு அப்படின்றதை calculate பண்ணலாம். for example, நம்ம யூசுவலா பார்த்தோம் 1 mm is equal to 0.04 second. 0.04 second is 1 mm. இப்போ 5 mm அப்படின்னு பார்க்கும்போது 0.2 second. கரெக்டா? 5 mm square, 1 mm square is 0.4. அப்ப 5 mm அப்படின்னு பாத்தீங்கன்னா 0.2. yes, அப்ப ஒரு நிமிஷத்துக்கு எத்தனை மில்லிமீட்டர் இருக்கும் அப்படின்னு பாத்தீங்கன்னா அதுதான் ECG strip ரன் ஆகிறது 25 மில்லிமீட்டர் ஒரு செகண்டுக்கு. சார் listen here, listen carefully, in 1 second you are getting 25 millimeter. அப்ப ஒரு நிமிஷத்துக்கு எவ்வளவு இருக்குன்னு பாத்தீங்கன்னா 60 into 25 multiply பண்ணீங்கன்னா 1500 அப்படின்ற வேல்யூ வந்துரும். am I clear? புரியுதா பாருங்க. 1 millimeter is 0.04 second. அப்ப 25 millimeter அப்படின்னு பார்க்கும்போது 0.8 second அப்படின்றது வந்துரும். அப்போ ஒரு செகண்டுக்கு 25 millimeter. அப்ப 60 second அப்படின்னு பாத்தீங்கன்னா 1500 millimeter, அதாவது 1500 small squares இருக்கும் ஒரு நிமிஷத்துக்கு. that means it will take 1 minute. am I clear? அப்ப 1500 divided by எத்தனை small squares இருக்கு, that is in between 1 hour to another hour. அத போட்டீங்க அப்படின்னா that will calculate your heart rate. am I clear? இந்த கான்செப்ட் புரியுதா பாருங்க. ஒரு நிமிஷத்துக்கு 1500 ஸ்மால் ஸ்கொயர்ஸ் வரும். அந்த 1500 ஸ்மால் ஸ்கொயர் டிவைடட் பை d அப்படின்றது டிஸ்டன்ஸ் பிட்வீன் ஒன் hour டு த அனதர் hour. ஒரு அப்ராக்சிமேட்டா பாத்தீங்கன்னா ஒரு 20 இருக்கும், 20 mm இருக்கும். இது தெரியுதா பாருங்க, ஒன் ஹவருக்கும் இன்னொரு ஹவருக்கும் இல்ல கேப் பாத்தீங்கன்னா see here, this is 1 hour and another this is also one more hour. ஓகேங்களா? இல்ல ஒரு பாக்ஸ்ல 5 mm இருக்கு, 5 mm 5 mm 5 mm and 5 mm. டோட்டலா பாத்தீங்கன்னா 20 mm இருக்கு, 20 ஸ்மால் ஸ்கொயர்ஸ் இருக்கு. But 1500 divided by 20 அப்படின்னு போட்டீங்கன்னா that value is 75. 75 is the heart rate. The same way 300. ஓகேங்களா? 300 அப்படின்றது லார்ஜ் ஸ்கொயர். ஓகேங்களா? ஒரு செகண்ட்ஸ்க்கு வந்து எத்தனை லார்ஜ் ஸ்கொயர் வருது அப்படின்னு பார்த்தீங்கன்னா 5 லார்ஜ் ஸ்கொயர்ஸ் வருது. அப்ப 60 செகண்ட்ஸ்க்கு 60 into 5 cr. இது ஒரு செகண்டுக்கு வந்து பாத்தீங்கன்னா இது வரைக்கும் வரும். See, listen carefully. 1 second அப்படின்னு பார்க்கும்போது 5 boxes தான் 1 second ரன் ஆகுது. கரெக்ட்டா? Am I clear? 5 boxes தான் ஒரு செகண்டுக்கு ரன் ஆகுது. அப்ப 60 செகண்டுக்கு 60 into 5 300. 300 divided by எத்தனை லார்ஜ் ஸ்கொயர் இருக்கு? ஒரு ஆர்க்கும் இன்னொரு ஆர்க்கும் இன்டர்வல் பாத்தீங்கன்னா 4 லார்ஜ் ஸ்கொயர் இருக்கு. அப்ப 300 divided by 4 பாத்தீங்கன்னா that is equal to 75. That is the heart rate.
Calculation of heart rate using AC.
கன்ஃபியூஷனா இருக்குன்னா chat boxல போடுங்க.
இது என்ன கேட்டமா ஹெல்ப் பண்ணிட்டு இருக்கீங்க? என்னடி அப்படினு கேட்டிருக்கு பா சார், அந்த டவுட்டுக்கு என்னடி அப்படினு.
Is there any doubts? Up to this over. Is there any doubt? Yes, girls, any doubt? Okay, you can post the questions if you are having any doubt. Okay, next session will be start in another 5 minutes. Okay, the next session will start in another 5 to 10 minutes, a break hour. In another 5 minutes, our next speaker is ready now. She will be joining now. In another 5 minutes. Is there any doubts, questions you can post in your chat box that will be explained now? Is there any doubts from the student side? Okay. One person or Arunath. Bipolar. See, listen here. I just mentioned one more time about the bipolar leads. See, this is about your bipolar leads. Let me explain one more time. Listen here. See, listen now. Bipolar leads, it has two leads. One is active electrode and another one is indifferent electrode. Indifferent electrode na inactive electrode. Okay, so active electrode that active electrodes, it carries the electrical potential that is generated from the heart. Okay, this is one negative. In the bipolar lead one active, one indifferent electrode. See here, one is connected into your right arm, another one more lead is connected to your left arm. Okay, negative on the right arm and positive on the left arm. Positive red color and negative on the it will be in black in color. Another one on the green color and the fluctuations avoid பண்றதுக்காக அது வந்து ground connection. If it is not grounded, அது மெஷின்லயே இருக்கும். ஓகேங்களா? இப்போ ground connectionல ப்ராப்பரா இல்லனா ECG strips வந்து நார்மலா கிடைக்காது. So black color leads வந்து right armலயும் and red lead is connected to your left arm. This connected lead 1. And at the same time, lead 2 is connected by connecting your negative electrode to your right arm and positive electrode to your left leg. Okay, that constitutes lead 2 and lead 3 negative on the left arm left leg la positive கொடுத்துருவாங்க. அப்படி கொடுக்கும்போது current flow எப்படி இருக்கும் அப்படினு பாத்தீங்கன்னா listen here, this is the direction. Usually we know that current அப்படின்னு சொல்லும்போது movement of electron தான் நம்ம current சொல்லுவோம். So electron வந்து negative charge அப்படின்றதுனால it always moves a positive charge direction. Okay, so current will move from the negative side to a positive side. This is the curve. This is the current direction. The same way, இப்படி மூவ் ஆனாலும் இதுவும் ஒரு பாசிட்டிவ் சைட்ல வருது, இது ஒரு வேல்யூஸ் வரும். பட் இந்த டைரக்ஷன் பார்க்கும்போது நெகட்டிவா வருது, ஆப்போசிட் டைரக்ஷன்ல வர்றதுனால இந்த பொட்டன்ஷியல் வந்து நெகட்டிவ் பொட்டன்ஷியலா இருக்கு. ஸோ டோட்டலா சம்மேஷன் டுகெதர் இட் ப்ரொடியூஸ் ஜீரோ அட் த சென்டர். தட் இஸ் கால்ட் அஸ் எய்ன்தோவன் லா. எய்ன்தோவன் லால இப்படிதான் சொல்லியிருக்காங்க. See here, ஒரு imaginary triangle பண்ணீங்க அப்படின்னு பாத்தீங்கன்னா potential will be at the center is always zero. எப்படி அது ஜீரோவா இருக்கும் அப்படின்னு பாத்தீங்கன்னா the potential of all the leads summed together it produce at zero potential at the center. இதுதான் Einthoven law. Any other doubts? Any doubts? You can post your questions in your chat box. Darunya Yam. What's your doubt, Darunya? And here action potential is little one more time she asked about action potential. Action potential simple. Vivala ketanga, what do you mean by action potential? Abin ketanga, whenever an impulse or a stimulus is given to the muscle, a small change in the resting membrane potential is called as action potential. Simple as a small change in the resting membrane potential is called as action potential. Or additional one word, whenever a stimulus is given. Additional ஏதோ stimulus கொடுத்தோம்னா resting membrane potential change ஆகிறது தான் action potential. Any doubts? Okay, next our next speaker is ready now. Am I audible, madam?
Yes, it's audible.
You can share your presentation, ma'am. One second.
Yeah, sure, sir. Yeah, sure.
Proceeding by on schedule, we now have the topic cardiac output. Now, we are very glad to welcome Dr. R. Gayatri Devi, MSc PhD, who completed her post-graduation in MSc Medical Physiology from University of Madras 2011 and completed PhD in Faculty of Medicine from Savitha University in 2019. Her field of interest in research is spirometry, respiratory physiology, stress, and nanomedicine. She has a total teaching experience of physiology to BDS, MBBS about 10 years. She has published more than 250 papers in reputed indexed journals. We are very glad to welcome you, ma'am.
Yeah, thank you for your warm welcome. First, I thank for the invitation for giving my offer for Purushothaman sir. Thank you so much for giving this opportunity to share the few knowledge on physiology to students. It's a good effort, sir.
Thank you, madam. You can share your presentation.
Yeah. Just a minute, sir. Is able to see the screen?
Yes, madam. Yeah. Yes, madam.
Now, sir?
Yeah, yes, madam.
The slide is moving or the first slide, sir? First
slide show. Yes, madam. It's visible moving now. Yes, madam.
Is it moving, sir? The slide is moving. Slide show
not moving, madam.
Not
Slideshow
moving.
பண்ணு.
I put in my slideshow only in my laptop. That's why I asked you, but it's not shown us, sir.
Now it's coming.
Is it now, sir?
No, not visible, madam.
Now, sir?
No, madam, not yet, madam. Or you can share your this one, madam, your presentation.
Yeah, sure, sir. Sure. Just a minute, sir. Just I'm sharing the slide to you. TGP.
Madam, or else you share your PowerPoint through WhatsApp, madam. I'll project from here.
Yeah, I sent you, sir. Did you receive it? No, just.
In 2 minutes, the PowerPoint will be shared. There is some technical error.
Sir, I present in this way because the PPT is
Okay,
not
okay,
attached in
madam,
the
no
WhatsApp to
problem,
you. I
madam.
cannot share your. Is it okay? You can present in this way.
Okay, madam, no problem.
Okay. Shall I start, sir?
Yes, madam.
Yeah, good morning to one and all. I'm very happy to share about cardiac output. I think you have a great idea about the cardiovascular system. So, in that very important topic is your cardiac output. I think this is a very important question apart from the cardiac cycle. So what do you mean by cardiac output? So cardiac output is nothing but that is the amount of blood. Please mute. I think someone is unmute yourself. Thank you. So the amount of blood which is pumped out by each ventricle per minute, that is your cardiac output. So that is the amount of blood for every minute heart is beating, right? So the amount of blood which is coming out from that only called as the cardiac output. So this will be dependent on two vital components, that is your heart rate and then stroke volume. So basically, based on this component only, your cardiac output can vary from the normal value. Okay. So how the cardiac output can be measured? It has a formula that is you have that cardiac output is equal to that is stroke volume into heart rate. So the stroke volume and the heart rate gives you the person's cardiac output. This cardiac output only decides
Madam, can I share, madam? Sorry to disturb you. Can I share that?
Yeah, sir. Yeah, you can share. So the cardiac output only determines how much the rate of blood flow to the different parts of the body. If the cardiac output is decreased, automatically the blood coming out from the heart will be decreased. So the each organ receiving the blood supply also will get decreased. Okay, up to this is your cardiac output. Next slide, please. So I told the cardiac output can be calculated by the formula that is your stroke volume into the heart rate. So approximately this cardiac output can vary between your men and the women. Okay. So what is why there is the difference between the gender means basically the body posture and the thoracic cage. If you take the male, the thoracic cage will be somewhat expanded and it is a large than the female. So the heart also little bit bigger than the female heart. So automatically if the heart is bigger, it will just receive the quantity of the blood or pumping out of the blood will be higher. That's why the cardiac output will be little higher in the male than the female. So the stroke volume approximately if you take that, the stroke volume is 80 ml and your heart rate is about 70 to 80 beats per minute. So if you take 80 into 70, approximately it gives you 5.6 liter per minute. So the normal cardiac output for the male is 5 liter to 6 liter. Okay. But for the female, if you take little lower, that is about 4.9 liters per minute. So this cardiac output also can vary between your healthy individual and the unhealthy individual and also for the athlete. So it is the state of the activity, how the the heart going for the activity and all, it will differ the cardiac output. So once the stroke volume is changed and the heart rate changes, automatically the cardiac output also can change. Okay, next slide, please. Next slide. So I told that based on the activity of the heart, the cardiac output can change and your heart rate changes, cardiac output also can change. And if the stroke volume changes, the cardiac output also can change. If there is an young individual, healthy individual, the heart rate can increase to 150 beats per minute during an exercise. That is the difference between the exercise. It may be a mild, moderate or the severe exercise. If there is a moderate to severe exercise, the heart rate can increase to up to 150 beats per minute. So if once the heart rate is increased, automatically the stroke volume also can increase. I told that the stroke volume is normally about 70 to 80 milliliter per minute. So during exercise condition, it can increase approximately 120 to 130 ml per minute. So automatically, once there is a change in your stroke volume and then heart rate, so your cardiac output can increase to 7 to 8 times from the normal value. So during exercise condition, it can increase nearly to 35 liter. From the 5 liter, the cardiac output can increase to 35 liters. So what do you mean by cardiac reserve then? Cardiac reserve is nothing but, since the heart is a muscular pump, right? So during exercise condition, it can expand and occupy the larger amount of the blood. So the difference between your maximum and the resting cardiac output will be called as the cardiac reserve. You may ask in 2 marks question. What do you mean by cardiac reserve? It's nothing but a difference between your maximum and then resting cardiac output. It's called as cardiac reserve. Next slide, please. Next slide. Yeah, then what do you mean by cardiac index? Okay, the cardiac index can, before slide. Yeah. So cardiac index can be calculated by cardiac output by body surface area. BSA is nothing but a body surface area per square meter. Okay. So if you take a normal human, that is the average human weight is about 70 kg. So the body surface area is 1.7 square meter square. Okay. So in that person, what is your cardiac index is 3 liters per minute per meter square of the body surface area. They may ask in 2 marks question. What do you mean by cardiac index? So just you can write as cardiac index is nothing but the cardiac output per square meter of the body surface area. If the person is 70 kg, the body surface area is 1.7 meter square. So the cardiac index is 3 liters per minute per meter square. So what is the clinical significance of the cardiac index? Why you have to know the cardiac index? So it is a very useful marker once there is the heart is functioning normally or not. Okay, the heart functioning is directly proportional to the pumping of the blood or the volume of the blood which is pumped out by the heart. That is nothing but your cardiac output. So this is mostly measured used in the intensive care medicine and then cardiac intensive care. So this is your clinical significance. Why you have to know the cardiac index. Next slide. Next slide, please. Yeah. So there are the 2 components which depend on cardiac output I told, right? That is your stroke volume and the heart rate. Then what do you mean by stroke volume? Stroke volume is nothing but a volume of blood which is pumped out by each ventricle per beat. Per minute is your cardiac output. Don't confuse with your stroke volume definition and then cardiac output definition. Cardiac output is per minute how much of the blood is coming out from the heart. Okay. So the stroke volume is the amount of blood which pumped out by each ventricle per beat, or sometimes they given as per contraction. Both are same. So it is approximately, I told that this is before I told 70 to 80 ml. So this stroke volume is dependent on 2 main factors. One is your end diastolic volume, another one is your contractility. That is a contractility of the cardiac muscle. These 2 will depend on the stroke volume. So how the stroke volume can be measured is nothing but the difference between your end diastolic volume and then end systolic volume. EDV is nothing but your end diastolic volume and ESV is end systolic volume. So I'll just continue further about the stroke volume later. So you know about the definition of the heart rate is number of times the heart beats per minute. So normally it is about 70 to 80 beats per minute. Next slide, please. Next slide. So what do you mean by ejection fraction? So ejection fraction, why you have to know whether the left ventricle is in a healthy state or not. That is, if it is healthy only, the maximum contraction of the blood is pumping out through your left ventricle. So whether the left ventricle is functional, is healthy or not, only you have to know. How to judge means by knowing your ejection fraction. How the ejection fraction can be calculated? Ejection fraction is calculated by stroke volume by end diastolic volume. Stroke volume, how you calculate that? You know that stroke volume is equal to 70 ml. If you don't know the stroke volume, if they given as an end diastolic or end systolic volume, if you take the difference of the 2, you will get the stroke volume. So when you tell that left ventricle has a healthy means, if the ejection fraction is falls between 55 to 70%, always the ejection fraction will be denoted or represented in the way of percentage. So if it is in the 55 to 70%, you can state that as the normal. If it is, if the ejection fraction is 40 to 54%, it is below normal. If it falls between your 35 to 39%, you call that is moderately below normal. If it is less than 35%, you call it severely below normal. So by the knowing the ejection fraction, you get an idea about whether the left ventricle is functioning properly or not. They'll give you a proper cardiac output to all the parts of the body. Next slide, please. So what are the determinants of the cardiac output? I told the stroke volume and the heart rate. But the stroke volume itself is dependent on two factors I told. One is your end diastolic volume and your contractility. Apart from that, you have the preload of the heart, and then afterload of the heart also determines the cardiac output. Next slide, please. So how the stroke volume can be regulated? So stroke, what do you mean by end diastolic volume and what do you mean by end systolic volume? Means the volume of blood which remains in the ventricle at the end of the diastole. I think you know or aware of the diastole means that is a relaxation of the heart. So automatically once the heart is get relaxed, it can accommodate or it can get more amount of the blood in the ventricle, right? So that gives your end diastolic volume. That is during relaxation time, the volume of blood and the remain in the ventricle only called as end diastolic volume. It is also they called as preload. Okay, always once there is the end diastolic volume increases, the stroke volume increase and your cardiac output also get increase. So they call us is directly proportional. The stroke volume is directly proportional to the end diastolic volume. What do you mean by peripheral resistance? Is nothing but the resistance offered to the blood flow at the peripheral blood vessels. That is called as peripheral resistance. Okay, this is they called as a afterload. Afterload always the peripheral resistance is inversely proportional to the end diastolic volume. Somebody raise the hand if you have any doubts. Govardhani, I think so. Yeah, if you have the doubt, you can clarify. I can clarify. Any doubts? Shall I continue? Yeah, that is if the resistance offered by the blood is increased, automatically the end diastolic volume will decrease. So it will reflect on your stroke volume get decreased and your cardiac output. Finally, the cardiac outputs also get decreased. Okay, so the stroke volume is inversely proportional to the end diastolic volume. So automatically it is inversely proportional to the cardiac output. Next is about the contractility. Contractility is nothing but the strength of the ventricular muscle, how the ventricle muscle go for the contraction and then relaxation. Based on the contraction and relaxation, only the stroke volume depends on it. If it relaxes fully and it can accommodate your blood more, so your end diastolic volume increase and your cardiac output also get increased. If it forcefully contract, it pushes out the blood forcefully out, so the cardiac output increases. So automatically your stroke volume is directly proportional to contractility. Next slide, please. So this is an overall idea about what are the factors affecting the stroke volume and then heart rate. I told that the stroke volume depends on three important factors. One is your end diastolic volume and another one is your contractility, right? So this end diastolic volume I told that is also called as preload. So this end diastolic volume is again depend on another many factors. So one is your venous return, another one is your filling time. So what do you mean by venous return? That is your right atrium, that is your superior and then inferior vena cava is opening on the right atrium, right? So once the blood is pooling into the right atrium through your superior and inferior vena cava, so that is called as a venous return. Once the venous return increase, automatically your end diastolic is from the right atrium or the left atrium and goes to the left ventricle and the right ventricle. So once the blood filling is increases, and automatically the end diastolic volume also get increasing. So this automatically depend on your stroke volume. So end diastolic volume is directly proportional to the stroke volume. So the stroke volume is directly proportional to the cardiac output. Next is about the filling time. So filling time, if you have the time given for the heart to fill more, automatically the end diastolic volume get increased So stroke volume get increased and your cardiac output also get increased. In the case if you take of tachycardia, what do you mean by tachycardia? That is nothing but your increased heart rate, right? So there is a lesser time filling for your heart when compared to the bradycardia or normal heart. Okay, wow. So once there is a filling time is get reduced, automatically the end diastolic volume is get reduced and your stroke volume reduced and cardiac output also get reduced. So the filling time is directly proportional to your end diastolic volume. Next is about your contractility. I told that the contractility is once the contraction is healthy, the ventricular muscles get strengthened or strong, and it will increase your end systolic volume. So automatically stroke volume get increased. So this contractility is mainly controlled by your autonomic nervous system and your hormones. Next is about your afterload. Afterload I told about is your vascular resistance. That is your peripheral resistance. So in the case of vasodilation, there is a more blood is coming. So mainly the afterload is inversely proportional to your end diastolic volume. Next is about the heart rate. Heart rate is mainly regulated by your autonomic innervation and your hormones. So once the heart rate changes, automatically the cardiac outputs also get changed. Next slide, please. Next slide. Yeah, this only I have just discussed in the previous slide. That is your cardiac output, how is get maintained. That is mainly see about your venous return. Venous return, I told that is your the blood is get filling by through your superior and the inferior vena cava and your pulmonary veins to the right atrium and then left atrium. So once the venous return increase, automatically your cardiac end diastolic volume, stroke volume, and cardiac output also get increased. So your venous return is directly proportional. Next factor is force of contraction. Once there is a force of contraction, it pumps the blood, pushes our blood forcefully out, so that your cardiac output is increased. And the heart rate is mainly regulated by your autonomic nervous system and then hormones, and peripheral resistance I discussed before itself. Okay, next slide. Next slide, please. So the same venous return. So venous return is mainly venous return again is depend on 4 factors. One is your respiratory pump, muscle pump, gravity, and venous pressure. Okay, respiratory pump, as such, you know that the heart is present inside your thoracic cage, so between your lungs. So during that intrapleural pressure is favor the filling force of the heart. So this will increase your venous return. Venous return increase, automatically the stroke volume increase, and diastolic volume increase, and your cardiac output increase. Okay, and gravity based on the gravity, the venous return also can change, and based on the venous pressure, that is venodilation or venoconstriction, the venous return is get affected. Based on if the venous return increase, the end diastolic volume also get increased. If suppose the venous return is decreased, automatically the end diastolic volume get decreased. Next slide, please. Next slide. So the force of contraction, how they declare, there are the 2 scientists, one is they called as a Frank and then Starling. They given a law. So it's a very important, you have to know if you are reading cardiovascular system, means you have to know this law. That is the Frank-Starling's law. What they states that the force of contraction is directly proportional to the initial length of the muscle fiber within the physiological limit. The within the physiological limit is a very important word you have to mention in the law. Okay, so there is a limit for the force of contraction. Okay, that is the meaning of it. The force of contraction is directly proportional to the initial length of the muscle fiber. What it means now? So once during diastole, the heart muscle is get relaxed, so the more blood is get filling during the relaxation period. So more and more get relaxed, it go for next period, you go for contraction. So more and more the muscles get relaxed, it contracts harder and pumps out the blood during the contraction. So that's why they called us directly proportional. Okay, next slide, please. So force of contraction, you have, there is a 2 thing. One is the preload and afterload. So preload, I told about the preload, and afterload is nothing but the vascular resistance I told. So preload is a stretching of the cardiac muscle fiber at the end of the diastole just before the contraction. So the cardiac output is directly proportional to the preload. So afterload is nothing but the force against which ventricles must contract and eject the blood. So it is inversely, the force of contraction is inversely proportional to the cardiac output. That is, afterload is inversely proportional to your cardiac output, and preload is directly proportional to the cardiac output. Next slide. Next slide, please. Yeah, next slide. So next is about the heart rate regulation, how the heart rate is regulated. So the heart rate is regulated by the three factors. One is your autonomic nervous system, another one is based on the chemical, another one is other factors. Okay, so if this you know that autonomic nervous system is mainly comprises of your sympathetic and then parasympathetic supply. Once the sympathetic system gets stimulated, the cardiac muscle go for contraction and increase your heart rate, and if the parasympathetic gets stimulated, the cardiac muscle go for relaxation and decrease the heart rate. So there are some such chemicals, that is your hormones or the ions also can influence the heart rate. That is your epinephrine. Epinephrine is secreted by your atrial medulla. Apart from the epinephrine, thyroxine also can increase the heart rate. So there are few ions, that is the sodium and potassium and calcium concentration also can interfere your cardiac muscle contraction. And the heart rate can vary on the age, gender, and if suppose you have the fever, that time your heart rate get increased, the body temperature increases, heart rate increases. And also for the athlete, there is a decreased heart rate because they have a more cardiac output than the normal individual. So the gender also and your physical fitness also may influence your heart rate. Next slide, please. Previous slide. Yeah, so physiological heart rate, if there is a case of bradycardia, I told the bradycardia is nothing but a decreased heart rate. So automatically, if there is a decrease in the heart rate, the cardiac output will Can you hear me? Can you hear me? Okay. So
Yes,
in the
madam.
case of tachycardia, yeah, thank you, sir. In case of tachycardia, there is an impaired blood flow, coronary blood flow. Automatically, there is a decrease in the cardiac function. There is a contractility will get affected, and so it affect your cardiac output. In the case of mild tachycardia, you can see there is a increase in the cardiac output. So this is the relation between your cardiac output and then heart rate. Next slide, please. Next slide. Here, okay, there is some physiological changes we can change, vary the cardiac output. If the age increases, as the age increases, it will increase your cardiac output. And cardiac output also, I also mentioned in the first itself, there is a difference between the gender. Female has a less cardiac output, comparatively less cardiac output than the female, and also in the body build, and in case of exercise and the high altitude also it can increase. In the case of pregnancy and in the case of sleep, it decreases the cardiac because all the muscles go for the rest, so it doesn't require more amount of the blood to supply for all the other organs. So automatically there will be a less cardiac output during the case of sleep. Next slide, please. So there is some pathological variation In the case of fever, anemia, and hyperthyroidism, you can see there is an increase in the cardiac output. And there are few conditions that affect your cardiac or decrease the cardiac output too. That is your hypothyroidism, shock, hypovolemia, hemorrhage, and congestive heart failure. Next slide, please. Okay, how the cardiac output can be measured? There are many methods available to measure the cardiac output. Few methods I can share here. There is your Doppler echocardiography and dilution method. In that dilution method, the most commonly using dilution method is the thermodilution method. And the traditional method to measure the cardiac output is the fixed principle and non-invasive modification, and many other methods also is there. Next slide, please. So fixed principle, they were asking 2 marks. So fixed principle is nothing but the amount of substance which is taken up by an organ per unit time, that they can taken as Q, which is equal to the arterial level of the substance, that of the difference of venous level of substance, and get multiplied with the blood flow. That is your F. Okay, this will give your fixed. By using, you have the formula for this, and you can substitute the value in this formula, will get the cardiac output. Next slide, please.
Yeah. Back out, that is. Back out.
So this is the relation of the cardiac output and then PP. So I told that the cardiac contractility and preload is just directly proportional to your cardiac output, and afterload is inversely proportional. So this will affect your stroke volume. Once your cardiac output is get increased, automatically it will get affect your blood pressure. Okay, so everything is connected together. So as a heart is go for contraction, same like that, the function also has a synchronized between all the things. Next slide. So if you take a case of hemorrhage, the blood volume get decreased automatically, or the blood volumes go for decreasing. So the mean circulatory filling pressures get decreased, and your central venous pressure also get decreased, and automatically the venous return to the heart will be get decreased. So once the venous return decrease, end diastolic volume also get decreased, and your stroke volume decrease. So it will affect your cardiac output, and you can see there is a decrease in the arterial pressure, right? So once there is a decrease in the arterial pressure, it can be sensitized by your baroreceptors. Baroreceptor, you know that there is a receptor which sensitizes, there is a change in the blood pressure, right? So once there is a decrease in the blood pressure, the baroreceptor, that is your carotid and then aortic sinus, get sensitized. So this will increase your heart rate, and by one way it will through your sympathetic, it will get activate your cardio oscillatory center, and sympathetic supply to the heart is get stimulated, and your heart rate is increased. So the cardiac output get increased, and your blood pressure is bring back to the normal. Other thing, it can increase your contractility rate. Once there is an increase in the contractility, it will just have an effect on the stroke volume, then cardiac output, then it brings your arterial blood pressure to the normal. Next, on the venous tone. So in the venous tone, you go for your regulate your venous pressure. So once there is a venous pressure is get regulated, it will just regulate your venous return to the heart. So it will just increase your venous return. Automatically, it will increase your end diastolic volume, then stroke volume, cardiac output, and then blood pressure. And apart from that, there is an ionic change also there in this. So salt and water, there is a balance between the salt and water, that is gets sensitized by your juxtaglomerular appendicitis cervini. That also brings back your blood volume to the normal. So the mean circulating filling pressure get increased. So venous pressure get increased. So automatically it affect your end diastolic volume, stroke volume, cardiac output, and then DP. So this is the link between your cardiac output and then blood pressure. So I think I have covered your cardiac output. Next slide. I think. So thank you so much for listening. So if you have any doubts, I can clarify.
Thank you, ma'am. It's the gratification and contentment that made the topic carry off by showering the glimpse of intelligence and making us a way more productive. Thank you, ma'am. Students are asked to raise hands or ask in chat box if any doubts.
Thank you, madam. Thank you for being with us for the presentation. A nice presentation, madam.
Thank you so much, sir.
Thank you, madam. Is there any doubt from the student side? No.
Okay, sir. Thank you so much, sir.
Thank you,
Thank you, sir.
Okay. The next session on blood pressure and then some other applied aspects related to cardiovascular system and coronary circulations that will be conducted after the lunch session. So here the session will be closed now. The session will start at exactly 1 o'clock after your lunch session. After the lunch, you will have a blood pressure and hypertension, and next session is your coronary circulation and shock with some applied aspects. We'll see after the lunch session. Thank you.